Thank you very much, everybody, for joining once more for Oncology Beyond the Obvious. In these monthly programs, what we try to do is to select one or maximum two articles and then discuss threadbare what is the implications of that article in the context of the Indian setting. For this, we start with an expert being interviewed, and this is followed by a panel discussion where another expert is the moderator. And finally, we have the third expert giving the concluding remarks. It has been a privilege for Amish and me both to have continued Oncology Beyond the Obvious with your help and assistance. And with your feedback, we always try and improve the program as much as possible. So with these introductory works, I hand over to Dr. Amish Vora, Program Director, to continue with the proceedings.
Thank you, sir. Can I request Kavina Creations to share my slides? Right. So today, next slide, please. Today we are discussing the New England Journal of Medicine paper, which was published in March 2024. And the title was Cell-Free DNA Blood-Based Test for Colorectal Cancer Screening. Next slide, please. So what they did was they had 22,877 patients, or the participants were enrolled in the study. Out of this, 10,258 were included in the clinical validation cohort. And finally, 7,461 were able to be evaluated. At the end of this, we will come to this, the last. Can I have the next slide, please? So what was the study? What is this paper about? All the enrolled people, I won't call them patients, they, after the consent, they were taken up for blood test. Their blood test was done. These tests were performed by Guardant, and who was the main sponsor of the study. Within 60 days of taking the blood, colonoscopy was performed on all these patients. So this was the mandate of the study. But this study went on during the COVID pandemic, and that's why the timeline was extended from 60 days to as soon as possible. So there were some patients whose colonoscopy was done at 80 days, some patients whose colonoscopy was done at 90 days also. So all the patients, their colonoscopy and their blood test were done simultaneously to see that colonoscopy results and the cfDNA blood test results done by Guardant, did they match or not? That was the whole purpose of the study. And the biopsy of abnormal lesions were taken in colonoscopy as we do routinely, and it was sent for histopath. Next slide, please. So as you can see in this table, the earliest age which were taken at 45 years, because as we know, the new guidelines by American Cancer Society and Task Force for Colorectal Cancer Screening, they all have reduced the age of colonoscopy screening from 50 years to 45 years. So we had patients from 45 years till 80 years of age. There were very few select patients who were above 80 years of age also. So minimum was 45 and maximum was more than 80 years also. The male and female, as you can see, there were more males than females, and there was a different racial distribution was there in this study. And in fact, they said that 68% of the states of America were covered in this study. So it was nearly representative of the entire US population as per the authors. Next slide, please. Okay, so colonoscopy, we all know what the results are. Of course, the histopath was done and there were precancerous lesions which were sent for central lab review also. But in terms of cfDNA study, what they finally detected, basically there were three things which they interrogated. One was genomic alterations, second was aberrant methylation status, and third was fragmentomic patterns. So finally, the result read as abnormal signal detected or normal signal detected. So cfDNA test was positive if any of these abnormal signals were detected, and it was negative if it was normal signal detected. Next slide, please. Okay, so this was the main crux of the entire study. Total, out of these 7,000 patients, biopsy proven on colonoscopy, the cancer detected was 65. While on cfDNA, that is the blood test, 54 abnormal signals were detected, and that makes the sensitivity of 83.1%. Stage 1, stage 2, or stage 3, if you see 48 patients and 42, and again the sensitivity becomes 87.5%. 1,116 patients had advanced precancerous lesions on colonoscopy, which I feel is quite high. Out of 7,000 odd patients who underwent colonoscopy, we could find so many patients having advanced precancerous lesions. Unfortunately, 147 patients were detected on cfDNA test, making sensitivity of 13.2%. Specificity touched on 89.6% and 89.9% in non-neoplastic. That is true negativity, what we see. Next slide, please. Can I have the next slide, please? Yeah. Next. 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 Yeah. So this was the hypothetical situation what they have created, that the authors said that in case if we have to take this test in public in hundreds and lakhs of patients, previous slide, please, then what will be the result based on the estimate? I personally feel this is more of a reassurance and tells us that finally what will be the value for money, but this is more of a hypothetical table, although in discussion part also this has been taken, and I'm sure Tarini also will take in his discussion. Next slide, please. Has this test got FDA approval? Yes, the FDA approved Guardant's Health's Shield blood test for colorectal cancer screening in adults aged 45 and older on July 29, 2024. This is just, 1 month and 10 days old approval. That means that based on the FDA approval, we can offer our patients this particular form of colorectal cancer screening whenever the patient appropriate average risk colon cancer patient comes in your OPD. Can we close the discussion, this presentation, and go for the discussion, please? Right. So it is my honor, as always. Sorry. Yeah. Sorry.
What happened, Amish?
Just 15 seconds, sir. Am I audible?
So if you can disconnect your audio from the second device, sir, there's an echo behind you.
Yeah, I have disconnected it. Now okay?
Perfect, sir.
Okay, perfect. So it's my honor to introduce, I always call my sir, my mentor, Dr. Purvish Parikh sir. Uh, Dr. Parikh sir has done MD, DNB, FICP, PhD, ECMO, CPI, and MBA. Uh, he has done MBBS from the same hospital where I have done MBBS from, that is KEM Hospital and GS Medical College. He was a fellow in oncology in Memorial Sloan and in Royal Marsden. He was professor and ex-head of the department in medical oncology in Tata Memorial Hospital. He was the convener of ICON, as we all famously know ICON. And I remember that, in fact, me and Chetan Deshmukh, we were present in the first ICON conference and the 50th ICON conference. And ICON was Dr. Purvish Parikh sir's baby. He was a group oncology director in Shelby. He was an editor-in-chief in Indian Journal of Cancer and many other journals. He was a past president for 11 years in SARC Federation of Oncology. He is the president of Molecular Oncology Society of India. He's the founder president of Asian Cardio Oncology. He has got multiple publications, and I was seeing his citations of publications today, and it went in thousands. That means his publications are cited by so many authors, and they keep citing his publications, and he keeps publishing whatever, according to him, is the relevant in the field of oncology. He's a teacher par excellence. I cannot identify any other teacher in oncology who have taught me oncology in a much simpler way than Dr. Purvish Parikh sir. Excellent human being. You call him at 2 a.m. in the morning and he will be there to help you if he can help you. But he also can be, if you request him that, sir, I want to be criticized, then be prepared. He will criticize you threadbare like the way we do OBTO. But at the same time, in spite of having so many achievements, I have yet to learn 100% team playing capacity of Dr. Purvish Parikh. He can be a very, very small, minute role playing team player, or he can be a top team player, and he will play his role excellent. It is amazing to be in the team wherever Dr. Purvish Parikh sir is there. OBTO, wherever I go, people say that Amish तूने बहुत अच्छा काम किया है, but OBTO is, Dr. Parikh is the backbone of OBTO, and nothing could have been possible without him, his support, his constant guidance, his constant criticism. After and before every OBTO, we both discuss, and I tell sir, please give me some criticism, not then, and we keep discussing that. And I can go on and on for Parikh sir, but I will, close here by one of his very famous saying that, Amish, please remember, no human being is a bad person. It is the situation and the circumstances which makes a person bad or good. Last warning, you can cross him anytime. He will forgive you for everything. Plus, please don't cross him with anti-BJP or anti-Modi comments. You have had it. With that, I close that. Welcome to show OBTO, Parikh sir.
Thank you very much, Amish. You mentioned that in case it is required, you can call me at any time. And you mentioned 2 o'clock. So I must specify that it is actually almost 2 o'clock here where I am in the early morning. I am in New Zealand, and it's a privilege to be here. And the
So,
other
sir, it's
thing
our
that I would
privilege.
like to remind you was that you and Dheeraj Abhyankar used to come to my home, and we would have such intense and vehement discussions, which my younger son would think that we are fighting, and then he would get scared about it. So those were
Yeah,
interesting days. Yeah.
he used to call us bad uncle and good uncle. And Kashish, if you are listening, you remember those old days. So I wanted to thank you, sir, for everything you have done for us and you are doing for us. And please be there for me and many like me in the field of oncology, sir.
It's my privilege.
Right, sir.
Thank you.
So we will start our discussion. First three questions are rapid fire questions, sir. Yes and no. Do you believe that this
Before
is a
you
practice?
start, I would just like to clarify something. While showing the slides, you had said that Guardian was the main sponsor. Actually, Guardian is the only sponsor for this.
Right, 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 sir.
And it is very interesting if you look at the disclaimer. There is one entire paragraph in which they have described at each and every step who was responsible for doing it, whether it was guardian, whether it was the co-authors, and specified the name or the number of co-authors, and what was done by the CRO and what was done by the authors themselves. And this study was initiated by the investigators and sponsored by Guardian. So I just wanted to clarify.
Right, sir. Right. Point well taken. Sir, first question. Do you believe this is a practice-changing paper, sir?
I think so, yes.
Yes. Do
I
you
can
believe
elaborate
in
on that
cancer
afterwards.
screening? Afterwards.
So
Do
that is
you
a very,
believe in
very,
cancer screening, sir?
I cannot have a simple yes no answer to that. So if you allow me, I will elaborate on it at an appropriate time.
Right, sir. Do you believe in colonoscopy is the gold standard for cancer screening for colorectal cancer, sir?
As of
Because
today,
we have
yes,
many
that
tests
is the gold
available. We
standard.
have stool test available, but colonoscopy is considered gold standard. Do you believe in that, sir?
I agree that today, under the current circumstances, colonoscopy is the gold standard for screening for colorectal cancer.
Screening for colorectal cancer, right? So, sir, my first question now you can elaborate, and that will also include: do you believe in cancer screening? But I wanted to ask a specific question that in case, say, you are developing a cancer screening for India and a primary endpoint, what would you keep? Would you keep as a all-cause mortality, or would you keep as a cancer specific mortality? I was googling, sir, because I was confused, and from 2007 till 2024 this debate is ongoing, that what should be the endpoint. Everybody wants to live longer. It is whether cancer or not cancer. So whether should it be all cause mortality, should it be cancer specific mortality?
So Viraj has put a chat that it is not colonoscopy, it is flexible sigmoidoscopy, and I correct
We'll come
myself.
to that, sir.
Whatever
We'll come to
Viraj has
that,
said
sir.
is absolutely right. Absolutely right. Now coming back to your question, ultimately what we want to do has to benefit the population. And screening is for a normal population, not people who have disease. So
Correct.
all cause mortality is the most important thing. We cannot say that we are doing an intervention that reduces deaths for one reason, but actually increases the deaths for another reason. So, all cause mortality is more important than a cancer specific mortality whenever we are doing a mass population screening, especially when we are talking about something which is for a average risk person, not for somebody who's high risk.
Right. But sir, majority of the studies which are being done is from the cancer specific mortality. They
Right.
keep all cause mortality, but that is mostly a secondary endpoint. So I'll tell you, sir, the people who are proponents of cancer specific mortality, they have calculated three different cancers, and they said for lung cancer, you need 40,000 people who are followed up for 11 to 13 years. And for colorectal cancer, the calculation goes as 6 lakh people have to be followed up for 15 to 20 years for all cause mortality difference to be seen. So, do you think isn't that too stringent? You will lose out on the specific test, like we always keep discussing of PFS and OS. In a hormone positive breast cancer, you will wait for decades. Like multiple myeloma, you'll wait for decades for OS to develop. Similarly, isn't it too stringent all cause mortality?
So, if you look last year in JAMA, there was a very nice meta analysis published about screening for cancers. And they were very stringent about what trials could be included. So they had to have all cause mortality and they had to have at least 10 years follow. And if you look at that, there were 18 prospective trials, screening trials, which were included. And the conclusion was that as far as all cause mortality is concerned, the only cancer where there is a benefit in terms of all cause mortality was colorectal cancer. and the increase in survival was like 116 days. So, not even lung cancer, not even breast cancer was found to have a improved all-cause mortality. That is the first thing. The second thing is that the benefit, the potential benefit of screening a population was found to be overestimated. So, for instance, they said that if the screening mammography and ultrasound and MRI was done for 1,000 women, 21 lives would be saved. But in effect, it was not 21 lives, it was one life. So, when you look at disease-specific mortality and a shorter survival in some of the studies, it is self-defeating because it gives an overestimation of the benefit of screening in a general population. So, I would still like to look at all-cause mortality.
Right, sir. So, unless and until it is an all-cause mortality difference, do you believe all the screening should not be applied? And that is a question. Do you believe in these cancer screening in absence of all-cause mortality, sir?
So, I would like to look at a very important R01 study that was done from Tata Hospital in the community, and that was
Correct.
for women's cancer. So, it was for cervical cancer and breast cancer. And the cluster of the slums in Mumbai were divided into those where there was no active intervention, and those where a lot of aggressive teaching and training was done about being aware about cancer and the need for regular checkup. And this had 80,000 women in each arm. So there has never been such a large group
Large
that was
study.
studied in India. And finally, the 20-year follow-up has been published. And in spite of being aggressive, in spite of being followed up with practically no loss to follow-up, at the end of 20 years, there was no difference in the aggressive, active surveillance group. So I think we have to be very careful about what we do. And this has been the
Right.
experience not only in India, but also elsewhere. But I specifically wanted to mention this particular study from India because it is our country. It was a large thousands of people, general population, and a follow-up of as long as 20 years.
So, at the point very well taken. So, what I get is that cancer screening is something which is not black and white, yes and no. It depends how you look at it.
So it depends on many factors. For instance, the cause of death or all-cause mortality is related to lifestyle, obesity, lack of
Correct.
exercise, eating red meat for colorectal cancer, and also, obesity. I already mentioned that. Now, these are factors that contribute to death not only because of cancer, but also cardiovascular causes or other related causes. So, if you are, if a person is screened for cancer, but continues the risk factors for non-cancer problems, then the all-cause mortality will not be affected.
Correct.
The other factor that we need to keep in mind is that most of these cancer screening trials were done at a time when effective treatment was not available. So if a patient with early breast cancer is detected or stage 1 and 2 breast cancer is detected, the chance of curing that patient with modern medicine is significantly higher than before. So the relative benefit of screening is lost because we have more effective treatment. And that is something that most people forget while looking at screening.
Right, sir. So you mentioned about Indian study also, and you also mentioned that you believe this is a practice-changing paper. So why is there is the need of this particular test in India, CFDNA, where we still have not standardized? Colonoscopy in India is cheap, readily available. Today, if I call 10 gastroenterologists, I think almost all 10 gastroenterologists will do colonoscopy tomorrow. There's a minimum hassles, daycare procedure. You do a biopsy there and you do the treatment of dangerous polyps in the same sitting. Why do we need this test, sir?
Very good question. The recommendations from USA about doing a colonoscopy from 45 years onward has one goal, and that is that 80% of the population has to be covered. But even in a country like United States, the coverage is only 59%. Let's forget United States, which has a population of 360 million people. Let us look at Singapore, a very small country, a very structured and a small educated population, and where screening is provided free of charge. Even in those circumstances, the percentage of uptake of the screening in the eligible population is only 27%. And while we were discussing this OBTO, we did a survey in India of more than 2,000 people. Okay. After eliminating those who were less than 45, we had about 1,100 people who were above the age of 45. And the people who have actually undergone screening colonoscopy was 7.8%. So even if you have a test which is 100% accurate and is 100% specific, if it is being used by only 7.8%, that gold standard in the real world is not being practically used. So if it is only going to cover less than 10% of the population, we have to have something which is more convenient or something that is enabling us to find the patients with colorectal cancer. And please remember that this Guardian Shield test is not a substitute for screening colonoscopy. It is only an addition for an average risk population. So that is why I think
So, sir, just
colonoscopy still
randomly,
remains the gold standard. Yeah.
yeah. So, just a random percentage, all these 2,000 people and 1,100 above 45 whom you surveyed, if the Garden Shield or if similar test is, say, 50,000 rupees or 40,000 rupees, what will be the uptake instead of 7.5%, sir?
So that is an anybody's guess of what will be the
Just guess,
uptake.
sir. Guess,
But
guess.
let me come back to the gold standard, that is screening colonoscopy. I, one relative of mine also had to undergo. And therefore, I actually spend a lot of thought and reviewed the literature on that. And what does it say? It says that 14% of polyps are missed even by the best of gastroenterology. And in effect, if you look at the cancer, 27% of cancer is missed. Why does that happen? Because the colonoscopy will take about 10 to 15 minutes. In that time, if there's a single distraction for a few seconds also, that area during the colonoscopy will be missed out. And that distraction is very obvious. Even when my relative was undergoing colonoscopy, I was there in the operation theater and I could see that somebody walks in, the operating gastroenterologist's eye, instead of looking at the screen, look somewhere else. And the scope is passed further down and we don't know what is happening. That is why today artificial intelligence programs are being used to enhance the efficacy of what the gastroenterologist is doing by identifying and green lighting those areas of interest so that they can focus more on this and the risk of missing them out is gone. So while the colonoscopy is gold standard because we don't have anything better, it is something which is not foolproof, and it is something where the uptake in the real world is absolutely low in the Indian context. So if there is an alternate where the population is more willing because it is more convenient, it is simple blood test, then definitely we should look at that. And again,
But,
I am reiterating that it is not a substitute for colonoscopy.
sir, your guesswork about the percentage uptake, just one ballpark figure, sir.
So you look at diabetes. Okay, we are the diabetic capital of the world.
The
Everybody says
percentage,
that.
percentage, the percentage.
Uh, So if it depends on two things. One is that 15% of our population can afford the treatment either because they have insurance or where they are, they are rich enough. In those instances, it will be more than 50%. For the others, it depends on whether the government includes them within the free schemes. So like Ayushman Bharat scheme is there, and every state has a thing. If the test for early detection and screening is included in that, obviously those people will also take advantage of it. So again, this test
So,
is
sir,
not going to be seen in adopted by the entire 100% of the population, but it will be significantly more than the 6.7% that are undergoing colonoscopy today.
so help me understand, sir. I'm a little confused here. You have said this 3 times that this is not a substitute for colonoscopy. Uh,
Right.
1 month back, US FDA has approved this Garden Shield test, 45 years and above, in average risk person for colorectal cancer. So, and the result, what I showed in the slide is either it is abnormal genetic mutations or normal test, right? It does not give me the report as you have cancer or you don't have cancer. So even those 25, 30, 50% who will take this blood test, do you think that they will have to undergo colonoscopy?
That is a very important question. So, what does the Chirantan will obviously elaborate in the panel discussion, but the test is based on uh, oncogenic mutations, on abnormal methylations, and the change in the fragment size of the DNA. Okay. On the basis of it, it is a binary answer. Either it is red, that means you have a high risk of cancer, or it is green, that says that there is no cancer. When supposing I am a layperson, I am an individual, and I do this test, and I get the red light, then my motivation to undergo colonoscopy will be significantly higher than a general population where they say, oh, mujhe kuch nahi hone wala. So I think the real value is in selecting a population which is more likely to undergo colonoscopy, and therefore we will be able to diagnose cancer earlier. Please remember, in colorectal cancer, if the colonoscopy is not done, among that population, if they develop colorectal cancer, the mortality is 76%.
Correct.
So that I think is an important factor, that it motivates and it gives an incentive for a person to undergo colonoscopy and therefore get early detection of colorectal cancer at a stage when it is curable.
So the again, sir, little bit of confusion in my mind again. You said those who don't have red line or red tag, they are the one who are normal test on CFDNA, and they may not be motivated to undergo colonoscopy. Sir, let me complete the
I said
question,
the
sir. Sir,
exact
1 minute.
opposite. I said the exact opposite. I was only talking about the red. I was not talking about the green at all.
So, sir, what happens to green people? Let me ask you that.
So green people will have a reassurance that they do not need to undergo colonoscopy. That is a psychological factor, which is the
Right.
deficiency of this test. Okay. So I think the real advantage of this test is if it is positive, it will motivate people to undergo colonoscopy and come to early diagnosis at a time when that colorectal cancer can be cured. If the signal is green, then we might actually be doing a disservice because the patient may have cancer, but it is still not picked up by this blood test. And they will be under the false sense of security that they do not need colonoscopy.
So this is precisely I have a problem with this particular test, sir. So if you see the paper, uh, they have 13% sensitivity of picking up precancerous lesions. And sir, we have
Right.
3 tests: colonoscopy, pap smear, and oral examination are the 3 tests which picks up precancerous lesions, which you treat them and you avoid cancer from being forming. So if we decide, let's say 10,000 people decide to take CFDNA test, out of which say 1,500 patients already have precancerous lesions in their colon. But this test will pick up only 160 by CFDNA. So remaining 1,340 patients will live in the false hopes or false premises that, oh, I do not have cancer. As you rightly said, I feel, sir, this is a big disservice to people. Do we really have the numbers to accept the CFDNA right now in our practice?
So tell me, does this not happen with the gold standard flexible sigmoidoscopy? I mentioned
Does it?
earlier that 14% of polyps are missed and 27% of patients with cancer are not identified on flexible sigmoidoscopy. So even the 100% gold standard of the test has quarter of patients which are missed out. So none of the test is really, foolproof, and we have to accept its limitations while applying it. So I would take that if the cell-free DNA test is positive, it is a blessing because it will motivate the people to undergo colonoscopy and have the diagnosis of colon cancer early at a time where they can be cured. But I also agree with you that a false negative test will be a disservice to the people who undergo the test.
So you mentioned about flexible sigmoidoscopy. I'm sure Viraj and Tarini will take it up. That is the only test which has shown to decrease the mortality as compared to colonoscopy. But today our topic is CFDNA versus colonoscopy. My second last question to you, sir, would be, first of all, flexible sigmoidoscopy, you mentioned 27% lesions are missed. Here, precancerous lesions, 87% are missed, sir. There's a huge difference between the two. But my second last question to you about the specificity, sir. Uh, you know, Specificity is true negativity. 10% of there's a 90% specificity in by this test. That means 10% patients will be told that you have cancer by this test, and they do not have cancer. According to you, sir, what specificity is acceptable for a
So
test to be
according to
routinely
you,
employed?
I will ask you about breast cancer and mammography. What is the percentage of specificity that is acceptable in mammography? You have
Sir,
Birat
it is,
stage, you are
yes,
divided into 10, and more thousands of women who do not have breast cancer unnecessarily undergo
correct.
biopsy, unnecessarily undergo the stress, unnecessarily undergo financial toxicity. This incidence of 10%, 90%, and 10% is much less than the false positivity of mammography. But still, we are willing to go ahead with mammography. In fact, Switzerland has said that widespread use of mammography is not encouraged anymore. And
So
the main reason
2016
is
onward,
because
they
of
have
these.
stopped doing it. Yeah, 2006.
They have
So,
not stopped doing it, but they have discouraged use.
correct, correct. So, Viraj said 90% specificity is excellent. My point is that mammogram also is not something, we can discuss about that some other time. There is a
Of
lot of
course.
zones there also. So, thank you so much. I think I have probably overshot the time. Uh, my last question to you, sir, again, I would ask you that do you think that this is a practice changing paper in India? And you have said yes, if you still remain yes, how would you put forth in front of, say, your family members or your friends that this test is available? I just want to hear how would you counsel them about this test, and then our interview is over.
If a person who's above the age of 45 years comes to me, I would say that you should have screening for potential colorectal cancer. And the gold standard is sigmoidoscopy or colonoscopy. If they agree to that, I will not offer these tests at all, the cell-free DNA. If they say, no, I will not undergo colonoscopy, and that will happen in more than 90% of instances, I will say, okay, then you have another alternate. And if you undergo this cell-free DNA and it is positive, then we will have a better we will be more reassured that you need a colonoscopy. So that is the people that I would like to offer. And please
Perfect.
remember that in our population, this is 90% of people above the age of 45 who do not undergo colonoscopy.
Right, sir. So we heard from the boss himself, although 13% pickup rate of precancerous lesion for me is actually no go for this test. But sir has put an excellent point, and I agree with majority of them, that when some form of screening somewhere needs to be instilled in people's mind, and whatever they are ready and whatever we have available, I think if it saves one life extra also, it is worth doing the thing. Thank you so much, sir, as always. Please be there for all of us, as I said. And you are also the panelist. And it is my privilege to call upon the moderator, because sir is a panelist also, Dr. Tarini Prasad Sahoo, medical oncologist from Bhopal. नाम सुना हुआ लगता है तारिणी आपका. We have panelists as Dr. Purvish Parikh, Dr. Viraj Lavingya, Dr. Chirantan Bose, Dr. Hemant Malhotra, Dr. Sunit Lokwani, and Dr. Lalit Mohan Sharma. Stage is yours, Dr. Tarini. Please go ahead.
Thank you. Thank you. I'll share my screen and give me a minute.
अंकुर अभी तक घर नहीं पहुंचा.
पैसा कमा रहा है.
As Dr. Amish said, I am saving one more life.
Wow.
Excellent, excellent.
Okay. So I think all the panelists are there. Can someone? Yeah. Okay. So we'll move on, and we will go down to the panel. And it was lovely to hear Purvish sir. I also would probably agree to some points of his and disagree to most of what they're told. But we'll have a good discussion. Let's see what would happen. That's my viewpoint. But there are experts too, and we have a lovely panel. Some very senior and some really dedicated to the cause of GI cancers. I see one of them, Viraj, looking very angrily into the camera. So, so let's start off with Lalit. Lalit, screening for colorectal cancer. Let's be realistic when we start off these questions. Do you practice that quickly? And if you do that, which are the patient lot and what do you do at this point?
In fact, for the routine population, routine screening, no. Only for the high-risk patient with positive family history or some other risk factors.
So basically, I put it that it's more of an opportunistic screening for a patient who was a high risk, probably has 2 to 3 more family relatives, younger. You would agree and then do the counseling and probably ask for the relatives to get themselves screened. So that's what it is. Viraj, any different, or do you want to add something more to here?
No, it's the same what we do here. It's opportunistic.
Okay. So can I ask other panelists, whoever are there, even those who are not in the to share in the chat, is there anyone who does a screening for colorectal cancer as we are pushing for maybe pap smear in cervical cancer, maybe a mammography, although Dr. Parikh did point out some points that could put mammography in the doc, but all of us agree that in a country like India, these do matter. Anyone in the panel? Dr. Hemant sir, Malhotra sir?
So I think I do request like my, obviously these are not patients, these are healthy subjects. To get an annual stool test done, certainly do not request them to get a colonoscopy.
Okay.
So at least a stool test for the intelligent and awake and aware friends of mine, I do request annual stool test done.
Okay, so not the FIT, it's just the stool, blood in the stool. That's what it is. Okay, okay, sir. I get you. Sunit,
I would like to,
sir,
Tarini,
sir,
the number of people, young people who are being diagnosed with colorectal cancer is increasing all over the world and including India.
Sir,
the youngest patient with colorectal cancer that I have seen is 13 years old.
rectal
and in
cancer,
fact, we are
especially.
bringing out a special issue on South Asian Journal of Cancer on colon cancer, colorectal cancer, in which the editorial is on young onset colorectal cancer. So while today we are not aware and therefore we are not doing screening for colorectal cancer as is being done in the West, I think we are missing out on a large number of young patients by not doing the screen.
Okay, so I will put few points and then we can take this point again and see whether Parikh sir has a point to make. So I know Viraj, I'll come to you last on this. You had put it on the chat and we had not shared slides. So Sunit, what is your take on sigmoidoscopy versus colonoscopy as a screening modality. I'm pretty clear on what we are speaking, and you're there.
Yeah, I'm there. I'm there. I'm there.
Yeah,
I
please,
just wanted
please.
to add to the last part, which was already going on. So we do encounter a lot of IT individuals in our practice coming to us with a very aware conscience that, sir, we need to get checked for so and so issues.
Okay.
So that is a specific subset which is normally being encountered in areas like Mumbai, Bangalore, which are an educated lot, who hear about, like, it's something like, if we used at earlier point of time, we used to hear that somebody has an MI in the colony, everybody used to start rushing and start doing their cardios and everything. So it's a similar thing is happening. If somebody in the vicinity listens to about that, it's so-and-so person is having a colorectal cancer, we should also get screened for cancer. So that kind of aware population is actually being encountered. And as Purvish sir pointed out, the young population, the young crowd, they specifically need these kind of intervention, like the CFDN one, which we are discussing.
Point taken. We'll discuss that, whether it is worthwhile doing screening to this person. I'll have few
that was my point
which,
in that.
Yeah, that's agreed. So can you speak about your talk on your thoughts on sigmoidoscopy versus colonoscopy? We had someone speaking that's flexible sigmoidoscopy versus colonoscopy. If it is one modality, what it would be? And what is the evidence?
If it is one modality, if you're asking, sir, I'll still go for colonoscopy. And Dr. Viraj will definitely lock horns with me on this one.
Let's not have opinions. That's what we will see what Viraj sticks to. Viraj, colonoscopy versus flexible, the debate. If it is the invasive modality, which one would you prefer?
Flexible sigmoidoscopy, especially after the New England article, which showed that doing colonoscopy did find although more cancers, obviously so, because you're seeing the right side also, but it had absolutely no impact on all-cause mortality. Flexible sigmoidoscopy being very easy office procedure, you don't need bowel preparation.
Ask you a counter question. I get that article, but my point is, if you have a colonoscopy once in 10 years, let's say sigmoidoscopy flexible, all-cause mortality was no different, but would you not rather prefer the precancerous lesion to be picked up on the right side, which is going to be heavily mixed? Even the transverse colon is going not to be there. If one patient comes to you and tell, okay, doc, I don't have any issues with the procedure. I understand the preparation could be much more. I need to be probably sedated. I totally take that point. I'm young enough to tolerate the procedure. I don't have any cardiac comorbidities. Do you feel the precancerous lesion, which is picked up much more on a sigmoidal colonoscopy, for the right patient should be the choice rather than the flexible sigmoidoscopy?
I completely agree. Of course. So colonoscopy, of course, will find more adenomas, more tumors, in fact, which was shown also in the study.
Yes.
But being a longer procedure was more complicated, and it offsetted whatever little benefit it offered in all-cause mortality.
Okay. So I think I wanted to bring this point very, very clearly, because the message that went on in previous minutes was that sigmoidoscopy scores over. It is not that. What Viraj told, that is the all-cause mortality was similar, but you do find more precancerous lesion, more malignant lesions, because you are doing the whole colon, and your purpose of screening probably does make a purpose, especially if the patient is not very elderly, and that could be a choice. So point taken. I have one also slide from the JAMA paper, which looked at the sigmoidoscopy versus colonoscopy, which I'll present in a minute. Dr. Lalit, this is a very big overlap. Screening versus early diagnosis. Quickly, your little difference, what is the screening versus early diagnosis? What is one point that defines both and differentiates both of them?
I think screening is for the normal population, where we are trying to pick up precancerous as well as the cancerous lesion and normal colon also. While early detection is only for the patients where we are suspecting colon cancer and we are able to pick them early.
Basically, we can frame it that for symptomatic or asymptomatic. If it's symptoms, then we go for early diagnosis, because we're going to treat the invasive symptoms, and for screening, it would be something that is not. So quickly, the elephant in the room. Viraj, do you think India requires a screening program for CRC? Yes, no. We will talk about it in a minute, but now for the yes, no.
Yes.
Yes. Hemant sir, with your expertise and we have seen cancer evolving over the last 30-35 years in India, do you think as a country, because screening needs a government assistance, screening needs more structured program. Do you think India needs this colorectal cancer screening? And do we have that point of the government justifying itself to spend that amount of money?
My categorical answer would be no.
Okay. Lalit, would you defy your boss?
Yes, I think for us, the other priorities are head neck cancer, cervix, and breast cancer. These are the topmost cancer where screening is easy and will be practical.
For you, it's a no also, I get, as I get it. Okay, Dr. Suneet and Dr. Purvish, sir. Yes, no.
So TP correction, please. I'm not his boss. I am his friend and colleague.
Suneet,
Please do not intimidate my friend and colleague.
okay, sir. Apologies. Suneet, does India require it?
Sir, in contrast
we leave that
yes.
technocrats away and just think of the reality of India.
So I'll go for the yes part of it.
Okay, done. Fair enough. So it's a 2-2. The tiebreaker goes to Purvish, sir. I know the answer, but I'll ask him still. Sir.
No, actually, you will be surprised. My answer is that it is not required. And the reason why I'm saying no is because there is no change in all-cause mortality for any of the screening procedures that we are doing. So not only for colorectal cancer, I don't think screening is required for breast cancer. I don't think screening is required for any other cancer as far as India is concerned.
Okay.
Tarini.
Especially for colorectal cancer, the incidence in the West as compared to the incidence in our country, thanks to the diet which most of our people have, is quite different.
Yeah, Amish and then Chirantan. I'll bring him in.
Yeah, Tarini, I think the answer to all the question what you have asked, whether the government aid is required in the screening.
Yeah.
What my question is that patients who come in front of us, they are relatives and they are caregivers. Do we believe that they should be encouraged to undergo screening at their own cost? I think that also I believe in that strongly. That that is something which keeps the person aware. Yes, government huge this thing with no all-cause mortality benefit mass across the screening program. No, but individually, do we believe in screening? Is a question.
Okay, so we'll answer that part of it. It's more of encompassing the opportunistic screening also. What Dr. Amish is trying to expand. Chirantan, I'll come to you for the specifics. But do you think, as a lab person, do you think colorectal cancer screening is a yes for now for our country?
So independently colorectal cancer screening, no, but as part of multi-organ cancer screening, yes.
You just are expanding the cohort totally differently. So we'll see that.
Sir, just one point to add on to the comment which I made, because the cost at which cancer screening, even with the most maximal of effort, can be brought down by any technologies, justifying a molecular screening approach for a single cancer, it will not fit into either a single person's pocket nor the government's pocket or the funders insurers pocket. So for just considering that point,
okay. So if you go through the articles and you do not have any specific articles from India for colorectal cancer screening, I have searched it. If I missed it, someone might share that article with me. So the best I could go through was the WHO articles and the articles from the third world country and probably the little bit poorer and the low middle income countries. This article comes way back, maybe 15-20 years back. I'll come to some recent articles also. The mass screening colorectal cancer is not justified in most developing countries. The reason is very clearly mentioned by all my panelists here, that if you look at the incidence as such, the standardized, the age-adjusted ratio also, and if you look at it in the developing country, it is around 10, in US and Canada and other European, it's around 40. But look at India, and it is around 3 to 4 is where we are actually. This is one major point, that colorectal cancer screening, as Dr. Hemant was pointing out, the load is just not there for us to talk about the colorectal screening cancer at this point of time. And if you look at the latest 2018 data set, it's around the same what was there 15 to 20 years back. And if you look at the estimates which are there in the same article in 2025 also, the population has increased in India. That's expected to happen. That's when numbers are going to increase but the percentage as such is going to remain the same. So basically, we do not have that load to come in. I will ask Dr. Hemant a very important thing. If you look at, sir, the WHO part of it and screening, it encompasses that once you screen, it is your onus that the patient who is diagnosed should receive the treatment. And this is the emphasis WHO has put very, very categorical. If you cannot do it, just to diagnose it has no meaning. So what do you think our country is still getting ready, or still we are far off from that scenario that we diagnose and everyone is going to get adequate treatment?
So, TP, my absolutely firm conviction is, and this will change in the next generation, and I hope it changes. At least in my generation, generation of Dr. Parikh and myself, and maybe Dr. Lalit, our focus should be to diagnose the malignancy, whether it be breast cancer or oral cancer or colon cancer or, more common cancer, lung cancer, diagnose them in stage 1 rather than in stage 3. So focus on the high risk people, the tobacco chewers, the patients with vaginal discharge, the patients with smokers with cough. See if you can diagnose them in stage 1 or 2.
We are still quite far away from that.
4. So yeah, that's what my feeling is.
Viraj, do you think
Lalit, Tarini,
yeah, sir,
in the state of Rajasthan, where I'm working with Hemant right now, the state government provides full treatment for all cancer patients. So at least in Rajasthan, it is possible that any screened patient who is diagnosed to have any cancer will get the full treatment free of cost.
Sir, can I get to that, Tarini?
Yeah.
In fact, to the government also, we approached and we requested them to include the cancer screening in the state government plan, but yet it is not like on the board. And we are trying to convince them to include the cancer screening and other health-related screening programs.
So I will not take that discussion further because there are issues with that part also. We are not going to discuss that. Otherwise, we'll go away from topic. Viraj, your take on now. What do you think? Do you think that these articles are right in justifying that India, with the point it has, the screening of CRC is not justified?
No, I do not agree. The data that you showed is pretty
Okay.
old. There was a recent paper by Dr. Raju Matthews from Kerala, and they did a study from their state, and the ASR, the age specific rate for colorectal cancer in India, is from 3 to 4, what you just showed, to almost touching towards 7. And if you see exact numbers, we almost have 80,000 new cases of known colorectal cancers incidence in India. And we have more rectums, we have more young patients. So I agree that we don't need government to spend on this, because we have a lot of other priorities as well. But in my clinic and in the locality where we are, I think so it's our responsibility to at least start offering them the fit test, which is currently available in India for 700 rupees. And if some of us can collaborate, the COVID test was available for 150 rupees. It was made in India. So if we can put our efforts, these kits are very cheap, 100, 150 rupees. We can do a mass screening for colorectal, and FIT is one which has shown equivalence to Flexig for for screening of colorectal cancer. So I'm a big proponent of FIT testing, at least in your nearby locality, and I don't expect government to pitch in.
So the FIT thing is definitely here, and the slide do tell us that FIT is probably a modality which is accepted, but not the best modality. You see others scoring over it, and we all know that.
It's the cost analysis, right?
Definitely. I'll come to a more important point. I think even if it is not 3-4, what I showed you, the Globocan 2018 data, which is relevant in 2023-24, that's the best data I could find out from a source which I could trust, not a single person's thinking. The second point which I wanted is something everyone should read through this article, being quoted in multiple NEGM articles and big articles. This is a beautiful paper from the UK guys. which they've looked at that what percentage of patients, and I want everyone panel's opinion to come in before I go to the test specific and the two papers which I'm going to discuss. They've told that if the 15 years cumulative risk of a colorectal cancer is 2, 3 or 4, they put it like that, and they have estimated on statistical analysis, and the answer they gave us was, if the risk of cumulative cancer colorectal risk in a 15 years was 3 and more, then screening could be justified. Otherwise, even in the Western world, they're very categorical. Even the Western world, screening was not justified. And there are multiple references to this paper. So, and does anyone ever has seen this? Because I did not till I read this paper. Viraj may have been. I did not know. This is the Q score for the colorectal cancer, and you use a calculator. And you just put in your age, and if you look at the ethnicity which is there, which is white is there, Indian is there, Pakistani is there, they're all things because it is from UK. And every categorical risk factor is there, including the height and weight, and then you push the button calculate below, and you get the risk here. So today I did it for a white, which is the European or the North American. It comes to 3.6 for the same group. When I put it for the Indian, suddenly it changes to 2. So Viraj, then I will go on to ask Purvish about this, and then Hemant sir, 3 of you. Do you think in your clinic, which you are opting for, with the evidence behind you, that if the risk cumulative in 15 years is not around more than 3 or more, you would not then advise the screening? So, and this calculator took me exactly 10 seconds. So would you advise this part to do it at least before we do opportunity screening?
No, so again, these are the nomograms, and these are done by UK for multiple diseases we know, and they are not reliable for our population. They have not sampled our population. We Indians have not sampled our population. How can they? These are the.
Should I correct you? In this nomogram, they have put Indians as a category specific, and we all know UK has a good Indian population. Right. I believe the science should be there. They just would not put something like that.
Let me flip a question to you. When you did your practice, how many rectums you saw under 40? And now you tell me how many rectums you're seeing over 40.
See, my point is the absolute number, let's be more realistic. The absolute number will definitely increase. The population is rising. The diagnosis is increasing. I have no questions about that. My point is, how can we streamline the screening process? I'm not against screening. Is this a good way to probably push your patient and tell them, boss, there is a data for 3% and more that the cumulative risk of 15 years could be pushing you. Your risk is higher. Please go ahead and do the screening test. My question was, can we have a bridge to further convince ourselves rather than screening everything and everyone who has pockets and money to afford the test?
So a fit test, which is very cheaper, if you do it every year, it's a very acceptable strategy in our country.
While I'm talking about this, Viraj, again, you're missing the point, is going to the costlier test. We are going to discuss in the next 20-30 minutes the NGS and the other tests. So where do you draw the line? Fit is 700, nothing doing. The other test will matter.
Yes, so I will not offer shield like Purvish sir said.
Okay. Sir, Purvish sir, your hand is up. Please, can you speak?
So there are two things as far as this nomogram or calculator is concerned. One is that when they say Indian, an Indian who has migrated to USA or United Kingdom is totally different from an Indian that is here. That is the first thing. Second thing is that the second is that they have a historical control. What incidence was occurring 10 years ago is not occurring today. So I would definitely agree with Viraj that this calculator is misleading. Having said that, I will still stand by my perception that colorectal mass screening for an average risk population is not required in India.
Anything to add before we move on? And Amish, anything you want to add till now?
I have already given my stance that, for individual opportunistic screening, we can take help of any test which has a good specificity and sensitivity.
So we'll come to that in the next part of it. I think I brought this up because I understood many of us would not know this calculator is there. And I think this can be, I felt it does not take anything away. It just gives an approximation. Probably you are more the person is more convinced to go for the testing. Okay. So today our discussion was about the cell-free DNA blood test, but I would not be doing justice till I also discuss the other paper which was in the same issue. And it was the next generation multi-target stool DNA for colorectal cancer screening. So I think these two tests has to be spoken and taken together. The first multi-target stool DNA testing was approved and the first publication came in 2014-15. So it is nothing new, but they have added few more ways of doing it. So Chirantan, your quick thoughts. Have you, for my first question, have you gone through the other paper which was there in the same issue, the next generation multi-target stool DNA test?
Yes.
Yeah. So now if you have done through and you have seen the things, very quick before you go to specific details, do you think of these two, not and with that confounding factor we will be comparing against between trials, which you think has convinced you more as a modality of cancer screen, colorectal screen?
So, sir, from a data standpoint, the multi-gene stool DNA test was very interesting because that is something which is not being done by every other lab. It had microbiome component as well, but it is not practicable. It is not practicable.
For reasons of?
Because of the complexity of that test, that to bring it to the clinic is much more cumbersome. That is what I could get from this paper.
Can you specify? Because when I was looking at the cost, and the cost in US dollars at least is parallel or little cheaper than the Guardant NGS. So what I'm pointing is now I'm comparing two data sets which are more new generation, which are looking at nearly the same parameters or two different points. One is looking at NGS in the blood. One is looking at the next generation multi-target stool DNA. It's again looking at the methylation part and the other four things which are specified. So and this is, you need a stool, and you need a stool, and that is where the test is done. And it looks also, and we'll see the sensitivity and specificity, and then we can have the experts comment on it. So Viraj, you have gone through the data set, and do you have some initial comments before you go to specifics?
For the shield?
Both. I want on a first hand, if you read the second paper, do you think, have you read it? And if you read it, do you think which one is better?
The shield is much easier, right? It's a blood test.
And that is the stool test.
Stool test is not fun because you have to pick it up and put it on the strip. And so that's why even the uptake of FIT in US is not more than 50%.
Okay. Any other panelists want to come in? Because this will be a very interesting discussion. Yeah, sir. Purvish, sir, please.
I think the next generation multi-target stool DNA test is actually more specific and more sensitive than the cell-free DNA test. Absolutely, there is no, the data clearly shows that the multi-target stool DNA test is better.
I will just go through this, and I will have the panels, and I'll just have some data sets, and then we can discuss. Probably this I brought in quickly because I felt these were two things in the same paper, and I think this really makes something. So inclusion criteria, I'll tell you the briefly. For the Guardant, we all know it is 45 years and above, and it had little more younger patients. It had patients below 50, around 8 to 10%. But in the stool test, it had little more elderly patient, and below 50 were around 3% only. So it majorly the median age was same, around 61 for the Guardant and 63 for the stool test. So these are two things which I wanted to put forward. The next important inclusion criteria which was different was the Guardant test did not allow anyone with a first degree relative with a colorectal cancer history to be allowed into the testing. While the multi-target stool test allowed first degree relatives to be done, but patients who had prior history of cancer and other things were common. I only pointed out two differences. One was the age. The inclusion criteria for the stool was 40 years onwards, but it was only 1% or less of the Persian population. Although they allowed 40 years and above, but the majority population was 45 and beyond. Sir, please. Purvish, sir.
So there was one other difference. And in the Guardian Shield study, anybody who had undergone screening colonoscopy in the previous 9 years was excluded. And I
Sir,
think that is an important difference.
Sir, both the tests had that. Both the tests had anyone within 9 years is excluded, fit within 6 months. If it is done, it was excluded. Everything was similar except for these 2 or 3 things which I spoke of. Slightly a younger age group. Yeah.
Also, the stool test, if it was done in the previous 3 years, they were excluded in the guardian.
Yeah, it was excluded, and in that multi-drug, 2 years only. I didn't want to mention that. So methodology and the statistics is little complicated. I will just come to that, and I will ask Dr. Hemant first. I'm not going to this. I just wanted to point out few things which is little more technical. I'll just come to this. Hemant sir, assume that you have a patient who can afford it. So now you have 2 tests. With the patient, you have access to both the tests. Then the discussion can be more practical. We first go to the garden test, the blood test, and we have a sensitivity of 83%. So I assume that of a patient who has malignancy in the colorectal cancer, 17 to 18% will not be picked up on the blood test. That's my taking on it. Second, I go to the advanced precancerous lesion. Only 13% are picked up, 87 are not picked up. Sir, are you satisfied and happy? As Dr. Amish was pointing out multiple times, he doesn't feel satisfied. What is your take on that?
So I'm also not satisfied.
Okay.
If I have to have a screening done, then I would like to, not know that I have colon cancer. I would like to know that I have a pre-existing condition which can lead to colon cancer. And the sensitivity of this test, and we're not talking about expense just now, even though the test is convenient, far, far more convenient than a colonoscopy. But the sensitivity of the test to pick up advanced precancerous lesions is only 13%. So that could be a major downside for me.
Guardian Shield test is only recommended for early diagnosis. It is not, nowhere in the paper does it say that it is recommended for advanced precancerous lesion detection. So we are all saying the same thing that is already there in the publication.
Yeah, agreed. But if I have to have a screening test done, then I would like to know whether I have a precancerous lesion which can lead to a cancer. That would be like extremely.
First, I think all of us are telling the same thing. If you use the word screening, it should be really the meaning of screen should be meant. And Viraj, I read your post, but come Chirantan, I will come to you on this. What do you think happened? Because this is too low. This is too low. And actually, this is even lower than FIT. The FIT has a sensitivity for precancerous of around 25 to 30%. What has happened?
Sir, if you see the supplementary data of this paper, continuing to what Hemant sir was just saying, but precancerous, we'll put it aside for a bit. But if we look at just stage 1, the supplementary data, because you want to screen in stage 1, there is no point in doing, stage 2 and beyond. So if you look at the sensitivity of stage 1, what the Guardant website also says, it is between 55 to 65%. Now,
stage-wise, this is a stage-wise from the supplement.
Correct. Correct. So you can see that, this, in fact, it is going down to as low as, I think, 40% if we look at the bar intersection.
The lowest, if they have come through for the 7 patients who had not been taken up for staging, and when they restaged it, 5 out of them were stage 1, and they put it, the sensitivity for stage 1 is 55%. It is below the margin of 65%, which actually the US FDA wants the sensitivity for colorectal cancer.
Correct. So, sir, now if you bring this point of stage 1 sensitivity, now the other paper which you actually showed, it sets a very good context because that paper had taken in FIT in conjunction with the study. So that is why its sensitivity increased. Now, just say that if at all the cost and other factors are taken care of, for a stage 1 go down to as low as 40%, then where does FIT stand? So I think that predominant question of a cheap, cost-effective screening modality which is available, which is other than flexible sigmoidoscopy, that factor is not being addressed. And I think from a practical standpoint for all your oncologist clinics, that question will come into picture when you are asking, I mean, any patient, whatever their socioeconomic strata is, you're asking to shell out 50,000 plus rupees for a colon cancer screening. Say, for example, there is no other identifiable risk factor except for, let's say, diabetes and obesity and all, and maybe a second degree family relative with a positive cancer. To convince that individual to shell out 50,000 plus rupees for a test which for stage 1 sensitivity may go down to as much as 40%, that is, there is a 6 in a 10 chance that he has cancer, he or she, and will not be picked up by this test. That question may be very difficult to answer. And just to, sorry.
Yeah,
Yes,
just
sir.
I want to point forward the stool test. I want to point forward, this is not spoken enough just because we do not have it, but this should be spoken in conjunction with the Guardant. Look at the sensitivity for the multi-generation, next generation multi-target DNA. The colorectal cancer sensitivity is around 92%, 93.9, 94%. And for the stage 1 also, the sensitivity is around 85% or more for this target stool DNA test. Even for the stage wise, I'll show you. Second, for the precancerous lesion, it is 43.4% in contrast to 13% which we saw in the Guardant. And the FIT test has a sensitivity of 23.3%. This is for the precancerous, which Dr. Hemant is speaking about. That should be the focus. And if I'm doing screening, I should be able to pick it up. The high-grade dysplasia was 75% for the multi-target stool DNA and 48% for the FIT test, which was again encompassed in the precancerous lesion for the Guardant, which was around 13%. Dr. Lalit, if I now compare both the tests, because both the tests have come in this generation, you have the sensitivity, and for the specificity, I want to just complete this. It is more than 90%, and the sensitivity of also the Guardant is around 89.5%. So we have the similar sensitivity. I want to tell you that on sensitivity parameters, actually FIT scores over both these tests, the specificity parameters. The specificity is more for the FIT rather than for any of these new tests. Dr. Lalit, now given an option, if someone has to do it, which of these two tests would you like to do?
I think FIT test will be much more convenient and acceptable based on the data.
Of these two tests, of multi-generation, multi-target stool test and the NGS for the blood?
The multi-agent stool DNA test.
Okay. Amish sir, boss, any thoughts on this?
Yeah, so Tarini, I was waiting. Before we go on precancerous or which method to apply, Parikh sir had mentioned in his interview that there is 76% of colorectal deaths happen because those were not screened patients. And this is a 2019 article involving, I think lakhs of patients what was seen. So even forget about precancerous on one side, and we can discuss and decide which test to be employed, blood or stool. But even in cancerous patients, even if we diagnose stage 2 with the sensitivity of 70% by this blood test, and as Parikh sir said that they can go for colonoscopy and they are identified and they have a 5-year survival rate of 90% as compared to when they develop symptom in stage 4, and they have a 15% 5-year survival. I think there is a merit towards this test. All I'm saying is that, it cannot be discarded the way everybody has said what is the use of this test.
I'll come to that also when I have a concluding thing, how this test can be adds on to the screening part. But Dr. Amish, just look at this and look at the stage 1 sensitivity for the stool test. It is 86% to 87% for stage 1, which is around 55 to 58% for the Guardant, and it is crossing 92% from stage 2 onwards. So my context was, are we too just obsessed with this Guardant blood test, and do we have a similar test with better results? Is something which I wanted to discuss in this panel and bring this out, because both tests looks very, very nice. Yeah.
Tarini, you are absolutely right in showing the data.
Yeah.
Sorry, sir, go ahead, please.
The best test is the one that is actually done. In theory, if a test is good, like colonoscopy, screening colonoscopy, and only less than 10% of eligible Indians are going for it, it doesn't serve its purpose. So also, it is also true for the blood test and the stool test. If the stool test is utilized by the majority of the people, then of course it is the best, better test than the guardian test.
What we will
But
do in the
like
last
somebody
part.
already mentioned, doing a stool test versus a blood test, I think there will be a significant population of people who would prefer the blood test as opposed to the stool test.
Okay. Viraj, we take this further. We had 10% of
Tarini,
patients.
5 more minutes.
Yeah, we'll conclude. We are coming to the conclusion part. Viraj?
Sir,
Yeah.
sorry to interrupt. There is one very important part of Cologuard or the stool DNA which we have not touched upon. Just for the purpose of education, I want to touch upon that. This is a very unique assay which is designed with 10 biomarkers, 10 DNA-based biomarkers, okay, which includes KRAS. It includes the ACT-B gene and the NDRG4 and another one. There is a huge, in the published data itself, there is a huge racial differentiation in the expression and mutation profile of these genes. This test has been completely validated on American population. Maybe there was admixture of participants in that, but application of this in Indian native population needs to be, because the KRAS data, at least for lung cancer, is already well published.
I think we're going beyond the screening point. I just wanted to stick to screening point of it. So I'll just stick to that. Otherwise, we will not. Yeah.
Unlike the blood DNA test, which is applicable to Indian population or to global population, this Cologuard test may not be applicable to global population.
I don't think that's the inference which the test happened. They also looked at the other parameters. They have the data set for the aberration, but that has nothing to do with the pickup rate for colorectal cancers. I will discuss that because I have only 5 minutes. Chirantan, I think we will, because 5 more minutes. We can have later on the chat. Viraj, NGS is positive, but the colonoscopy is normal. And 10% of patients did have this.
Yes.
How are you going to handle this patient?
So these are the false positive signals. It takes your sleep away, takes your patient's sleep away. But this is what it is. I think so. Specificity of 90%, which we discussed in Sir's interview. I think so. It's a reasonable screening test from that point of view. I don't know any screening test which has 100% specific. So 10% wrong positive or wrong signals is okay, I guess, in the current day and world.
You don't think it's a high number?
No, it is not.
Okay. This was not the case for the stool test. I'm not fighting for it. I don't have any shares in the company.
So no, even in the stool test, the specificity is 94, 95.
No, the stool test, the specificity was 91%. Is not that.
That means 9% is still wrong, right?
No. I think we're getting the specificity in a different point. Specificity, what they mentioned was with a normal colonoscopy with relation to those who did not have. This was patients who had this positive uptake and did not have a normal colonoscopy. Is very different from what we are speaking actually.
It's the same thing, 91%.
No. Okay. We'll come to. So you would follow them up every yearly?
It is supposed to be done yearly, yes.
Even
the shield or fit, whatever you do, you have to do it yearly.
So you will do. Yeah, please.
So in fact, like last year only, there was one test called GAIL, GAIL. So that was also multiple risk factors detected on NGS platform. And it was mentioned that we can do that test in patients who are positive for that test. They are at high risk. At that particular point of time, the test may be positive, but the colonoscopy or other test may be negative. But that predicts that such patients should be undertaken screening in a vigorously, like annual colonoscopy or such thing like that.
No, sir, that has not been proven
in the Guardian Shield publication. Those who had a false positive are still being followed up to see if they are going to develop cancer in the future.
We don't know actually
what's something that we will know.
Yeah. So I think this is well answered. Just a quick word. Thoughts on colonoscopy once in 15 years. There was a big paper in the early part of this year. Anyone wants to take it? can we do colonoscopy not in once in 10 years, but those who have a normal colonoscopy and of normal risk patient, which this paper caters to. Rather than doing it once in 10 years, it has shown that once in 15 years, you are not doing any disservice. Quickly, Viraj, have you changed your practice with this?
So even once in lifetime is a good start.
I think this again I wanted to bring in, not the 10 years thing. This is coming to for a normal risk patient, even a good normal colonoscopy, you can delay it for 15 years. So that can be done. I just want the last point and then I can stop here. This is a beautiful paper from Alaska, which is a part of US, the richer part of US actually. The health expenditure much higher, the economy is much better. And if you look at it, I just wanted to point two things. Look at the colonoscopy sensitivity alone and the colonoscopy sensitivity after a FIT test or a stool DNA test. You have to look at two things, and this is where, Parikh sir, I think your answer will come in. That if you do a colonoscopy alone in the best of centers also, the acceptance is around 60%. That's what the world data is all about. 40% still do not adhere to. But look at the sensitivity, it just nearly doubles or more when you are doing a colonoscopy after a particular screening test is positive. So point is, what Dr. Parikh told, once a thing is positive, the colonoscopist looks at it much more carefully. They're more likely not to miss lesions. And that is probably where I think this is going to come in. Let it be FIT, let it be stool DNA, let it be a Guardant. Once you are positive, you will have the colonoscopist doing it much more sincere, and the likelihood of missing will be much, much, much lesser. And this is also proven in a trial setting. And this is the data which I wanted to bring out. That look at the sensitivity alone for the adenomas. It jumps from 25 to 35% to around 50 to 70%. Just because the screening test was positive. So I think this is where probably we are going to land up with. And this is, I thought this should be my closing comments, that yes, this test does have its pros and cons. My take home for today was screening for CRC is required for countries having a higher incidence of the disease. Dr. Parikh was very categorical. No, India doesn't need any screening program. Few of us feel that cervical cancer screening can be done because it affects the lower majority. 25% of the incidence comes from India. Mammography we can debate about. The cost benefit analysis is important. It could be country and region specific. In India, unfortunately, we do not have a single published data of colorectal cancer screening. So that is something that is lacking. Population eligible, not consenting for colonoscopy with annual or biannual FIT. The modern test appears to be a great value addition. That is, I think, was my thing, that we just cannot shun it off, but it is too costly. The specific sensitivity for 13% and stage 1 of 55 to 60% is just not good enough. And if I compare both the things, the stool one scores over it. Of the two tests, I think the stool next generation multi-target testing appears to be better. What I felt, my two panelists disagreed, but I felt that the Q cancer calculator can be a handy tool. You can probably motivate your patients. If the cumulative risk is 15 years, is 3%, 5%, probably you can push them for the screening program. Any last line words from my panelists? Anyone?
So Ankur is here. Finally, he has reached home. And we must congratulate him because I think today itself he has been felicitated for his ESMO data. So Ankur, please share that data or some comments on that, please.
Sir, Hemant sir first. He was talking and then we can bring Ankur.
So just food for thought in the more affluent settings, maybe as a trial in a select group of people, like the sample collection is the same. If you look at the FIT plus the DNA test in the stool, then can we, with the same sample, increase the sensitivities and specificities? One sample collected, do both things.
Sir, actually, they have done that. Actually, also the stool DNA includes the blood hemoglobin in the stool. Actually, it encompasses that. Actually, it is a mixture of the taking the best of the molecular thing which you have developed, and also it calculates it looks at the hemoglobin in the stool. So it actually combines both. Actually, sir, the stool test. Anyone in the last comments? Viraj, anything you want to add? Ankur, please, the stage is all yours.
Yes, sir. Yeah. Yes, sir. Thank you. Thank you so much. And I think this edition of Oncology Beyond the obvious is obvious oncology, and the world is moving, and it's not the obvious, it is obvious that the whole genome sequencing, we have biopsies, liquid biopsies, which can actually not replace, just add on to the screening principle. I have made my notes in last 2 hours and 1.5 hours, and I'm listening every word to it. With permission of Dr. Purvish Parikh, because Dr. Amish rightly said that he's the man who can actually make everybody comfortable, and he made me comfortable by giving me an expert chair. So I would go with the principles of screening. My PSM
Ankur, he
Park
can make
textbook
everybody
say that
uncomfortable also.
no, sir, yes, sir. I agree. So let's stick on to sir. So if I remember my PSM book, Park and Park, screening is that test which can be done everywhere. It should be the cheapest test, like pap smear, mammography, and it should have a direct impact on mortality. These are the three principles which screening is based on. But I disagree with Dr. Parikh that India doesn't need. India, we have proved in cancer registry from Barshi and the metro cancer registries that the mortality of cervix cancer has gone down not because of vaccine, but because of screening cancer in a rural population. So India needs new screening principles like HRCT in lung, and certainly in the presence of metabolic syndrome, when obesity is round the corner. I am also obese a bit. I am at average. Yes, if you take my family history, you will find some association. So yes, India needs screening principle, redefinement of the screening policies. Colonoscopy versus flexible sigmoidoscopy. I totally agree with Dr. Viraj, but these guidelines were made, although he referred to NEGM, these guidelines were made when the principles of screening were just maturing. But we have to revise our Robbins also pathology textbook, which says that adenoma to carcinoma sequence. There was an adenoma and there was a frank carcinoma, which also explains the natural disease that it takes many years from adenoma to a carcinoma. And Dr. Tarini rightly said that right side of the colon deserves equally with the left side of colon. So gatekeeper genes and the genic abnormality and the cell-free DNA, we have to identify that, and the NGS identifies those tests only. It is not replacement of colonoscopy. Rather, it will promote colonoscopy. If you say somebody that you are 45 above your average risk, and this cost is going to fetch 1.4 lakh or 1.8 lakh, whatever is the cost, they will say, डॉक्टर साहब colonoscopy ही करवा लेते हैं जो 700-800 रुपए में हो जाती है. It is going to add-ons to my screening, and it will 1.4 lakh. I will get colonoscopy 10 times in my life for spending 1.4, and Amish bhai and Purvik sir will agree to it. It's cost-effective benefit ratio also we have to see. Thousands of gastroenterologists, but 3-4 molecular oncologists in the country who has the ability to read those tests. But brilliant people are sitting. The DM gastroenterology program probably was the oldest one, and the molecular oncology is just a decade old. So it is not replacement. It is just going to add. People will have more colonoscopy. Screening specificity, sensitivity, and specificity. Yes, gold standard cannot be matched, but we have to do something for these patients who are not willing to take down their pant and going to a colonoscopic room. I just give a analogy that everybody in my country needs a car. If everybody needs a car, they will not get Mercedes. They will get a Nano or a Maruti. So get the basics first, then we can go. But those are, there are market for Audi and BMWs and Porsche of the world also. So we have to individualize in this world who are obese, who are metabolic syndrome, and this. So government aid for flexible sigmoidoscopy and colonoscopy, totally agree with Viraj. Stool multi-generational testing, yes, fig. But colonoscopy is required once in 10 years, and this FIT or this blood-based test is required 1 to 3 year or 1 year. So Dr. Amish and Dr. Parikh and Dr. Hemant sir, the flowchart of this test is still not made. The science is evolving. False positive signals or actually true adenoma sequence or a APC gene or something. So we don't know. 15 years colonoscopy, once in lifetime colonoscopy. So getting mammogram to our mothers and buas and is so difficult. After the most difficult screening test, pap smear is also difficult. Mammography, head and neck, HRCT is most easy. PSA testing. So these are evolving screening tests. But this edition of oncology beyond the obvious is obvious oncology. Congratulate Dr. Amish sir, Dr. Purvish Parikh sir for sitting in New Zealand and sitting in Hope Cancer Center. I'm sitting in my Hope and I could see 71 attendee. You cannot get 71 attendee ever in whatever form you can do. Congratulations to oncology, obvious oncology. It is not beyond. It is the need. Get yourself screened, and whatever way I have to identify a precancerous adenoma polyps in an average risk, and I want to save myself and my family, and we get something out of it. So, need of an hour, something should be done for colon cancer. There's not epidemiology, it's not as common, but yes, the trends of GI cancer. Dr. Viraj is the elephant here. He knows GI cancer best in our country. So, an editorial or a letter to editor on this OBTDO is need of an hour so that we all, panelists and the experts from Lalit Mohan sir to Hemant Malhotra sir, can be author to this editorial that India needs a screening for colon. It is the right time. Over to Dr. Amish, Dr. Purvish Parikh, all the extreme panelists.
Thank you, Ankur. Parikh sir, I think sir must be, खत्म हो और अब मैं सोने को जाऊं.
Absolutely. But it was very stimulating, and I think all of the panelists, Dr. Ankur, Bahl and Dr. Tarini, did a fantastic job of bringing out the finer points. And it's my only thought process is that an ideal test is useless if it is not followed by the majority. So we have to use a bouquet of tests and see whichever the person in front of me is willing to do, that is what we should follow. Over to you, Amish.
Done, sir. Thank you so much. As always, as Dr. Ankur said, that it is OBTO, Ankur, because of people like you who encourage us, we try to do better and better. And I think, Ankur, you should also be equally part of OBTO. Whenever required, you always come running. But I think we will take your help in improving this. Tarini, before I sign off, I want to see your portfolio. फिट का कहीं ना कहीं तो तुम्हारे पास शेयर होगा ही होगा. I can guarantee that. But I think this was a very, very mind-stimulating session. For me also, I must say, we all read a lot, we all learned a lot, and I think there is no right answer here. We will keep evolving. See you all next month, second Tuesday. Every month, second Tuesday, we have OBTO, and we hope to see you all at that time. Thank you so much. And with Parikh sir's permission, I think we should close the session.
Thank you, everybody.